Right now, I'd like to welcome Dr. Narpinder Malhi, one of our consulting child and adolescent psychiatrists and the medical director of the Child Psychiatry and Multidisciplinary Autism Program at Christiana Care. She is our speaker presenting information today around managing suicide in pediatric practices. Dr. Malhi, I'll turn it over to you, and we'll skip, if folks are not already familiar with DCPAP, there is an introductory slide. Again, you'll get a copy of today's PowerPoint for your reference, but if you have any questions about DCPAP and our services, including trainings like these, you can let me know. Dr. Malhi, thank you.
Thank you, Mindy. Can you hear me fine?
Yes, wonderful. Thank you so much.
All right. Thank you. I am going to keep this view because I'm not able to see the notes, but hopefully that should be okay. That's okay with the folks. They are able to see my slides. But if not, just let me know, then I can go into the presenter view as well. If that's not like if the slides are not very visible. All right, so I do not have any financial disclosures except I am a consultant for Delaware Child Psychiatry Access Program. And today's talk, I think I want to make it a little bit more engaging and wanted to know challenges our pediatricians face in their practices as well. So for didactic material, I'll try to cover like what are the risk factors associated with suicide in children and adolescents, and what's the systematic way of assessment of suicide risk in this particular population, and what do you do when you have someone with high risk suicide. So let's go over. I shifted to the other side just to make it more bigger in font. So suicide trends, you probably know this by now, but there has been a significant increase in suicide among the population. I'll show you a little bit more data also among age 10 to 24, or even in the younger age group as well. In 2020, suicide was the 10th leading cause in 5 to 9 years old, second leading cause of death in 10 to 14 years old, and the third leading cause of death in 15 to 24 years old. And pandemic hasn't helped us anyways, especially with the behavioral health. Emergency department visits significantly increased for suicide attempts, especially among adolescents 12 to 17 years of age, and significant shift in for the girls as compared to the boys. But both had an increase in emergency department visits within the pandemic time. So this is the children's hospital data from all the children's hospital emergency department data between 2016 to 2021, basically a little bit after pandemic also, where we see a incremental increase in suicide, self-injury cases between the age of 5 to 18. And this increase from 2016 to 2021 was 168%, which is concerning and alarming for all of us who are significantly working with the pediatric population. So we always think about like, oh, suicide may be probably more in the adolescent age group and things like that. But I want to show that how important it is to screen all the children that come through our doors, especially the preteens. Suicide rate in that age group increased significantly from 8.2% from 2008 to 2022. And the greatest increase was seen in some of our diverse patient populations, such as American Indian, Alaska Natives, Asian or Pacific Islander preteens, and also Hispanic preteens. And this increase in suicide rate, as we've seen in the previous slide also, was more so associated with increase in these suicide attempts in girls. And one of the most common way of doing suicide that was utilized was firearm suicide. And we'll look a little bit more into this data in the incoming slides. So really important to keep in mind that our preteens, younger children, are also not immune to suicide when we compare to our older adolescents. So this is again furthermore looking into the data for younger children and suicidality. Children under age of 12 plan, attempt, and die by suicide. So these are different reports that are published across hospital pediatrics, JAMA pediatrics, where they have seen that how important it is to screen preteens for suicide among different settings. And some of the settings they have seen is emergency department. For example, in a study published in 2019 showed that 29% of the preteens, which is 10 to 12 age group, screened positive for suicide. And again, published in 2019, same in JAMA Pediatrics, also showed that 43% of suicide attempt and suicidal ideation visits to emergency department were for children ages 5 to 11, which is again like very concerning that what are we doing for these children? And then again, another published before that in 2015, where they also saw a racial disparity that children who are younger than 12, the higher rate of suicide was seen more for Black children compared to our white children. So really important to keep in mind that there is a significant suicide risk in our younger population and also significant disparities that certain populations are at higher risk compared to others. So this is again the age-related disparities in US data from 2001 to 2015, published in 2018, and where they showed that among children aged 5 to 12 years old, Black children had a significantly higher risk of suicide compared to others. And between 13 to 17-year-old, suicide rate was approximately 15% lower among Black youth as compared to white youth. The reasons being unknown, it could be possible that maybe these are the children who are not coming in contact with the behavioral health as much. But certainly there is a significant disparity in suicide in Black children compared to others. And then this was again published by CDC, where they differentiated the suicide prevalence by either by ethnicity, race and ethnicity, and by age. If you look on your left side, the graph that shows by ethnicity, and although the darker black bold line shows kind of like same that 2018 to 2023 overall suicide rate has been kind of close to the same. But if you look at different subset of populations, certain populations are impacted significantly more than the other populations, such as our top line, which is for American Indian and American natives. And then there is also increase in our Black and African population and Native Hawaiian and Pacific Islander. So some of the populations are significantly impacted more compared to the others. And similarly, in our age range, although the suicide is certainly lower compared to the older population, like 25 to 44 or 45 to 64 or greater than 65, but it's certainly still significant enough that requires more interventions from healthcare professionals working with this population. So knowing that now we have
Dr.
gotten some
Malhi?
understanding.
I'm sorry, we do have a quick question in the chat. Okay. So
let me
one of the
see
providers indicate that they use the PHQ-9 for children 12 and above. What do you recommend in terms of screening for preteen 10 to 12-year-olds?
We're going to come to that.
Okay,
Let me
thank
just
you.
so I will certainly make sure to cover that screening. But I will keep that question for just a wait for a few more minutes. So I'm not able to see the chat. I try to screen. I think, Mindy, you may have to keep an eye on the chat. I try to even minimize my screen share view, but it's still not visible. But anyways, that's fine. I'm not going to go into logistic and waste time. But now going to the risk factors for suicide, as we talked about, gender is one major thing. We know that suicide attempts happen more in girls, but completion rate is more in boys. So something to keep in mind. And leading method of suicide in 10 to 24-year-old for all genders is firearms, number one, followed by suffocation, followed by overdose or poisoning. So why this is important, that's where our safety planning gonna come in. come in action when we know there is somebody who has a positive suicidal ideations. And then suicide in individuals 15 years of age and older, suffocation was the most common method of death for our gay people, gay male adolescents, lesbian female adolescents, bisexual individuals, and so LGBTQ community. That's where suffocation is certainly utilized as a primary method for suicide compared to the others. So some of the high risk population, we did talk about the ethnicity factor. Some of the racial ethnic disparities do exist where certain populations are at higher risk, either are Alaska American, Native American, or biopic individuals, by Black, Indigenous, and people of color, and LGBTQ people. So something to keep in mind when you are working with this particular race and ethnicity population, to keep in mind that how they are at higher risk compared to others. And then our neurodevelopmental disorder kids, such as on autism and IDD, usually in this particular population, common assumption is, but there is a bias that their challenges may not be similar as others, and they are at a lower risk. But what we have seen is the suicide is also particularly higher in this population compared to others. And the significant one of the another barrier that comes in this population is their ability to communicate when they're experiencing these challenging thoughts. So it even become more burden on the providers how to figure out that we are making sure that these children are also safe. And then children in welfare system involved with the child protective services, or in rural areas where access to services is already limited. And then also in juvenile justice system, where there is a higher rate of suicidal fatalities and higher suicidal thoughts and behavior. But also keep in mind that there is a limited access to mental health resources in such settings. So that put these kids even at a higher risk for suicide. So a few other risk factors that we have noticed is like somebody with a history of psychiatric disorder, which you always know that somebody coming with a depression, screening for safety is so critical. And somebody with a previous history of suicide attempt, I always keep that in mind, because having a history of suicide attempts put the person at a high risk for another suicide attempt in the future. Or even current suicidal ideations or current non-suicidal self-injurious behaviors. Yes, they may not be getting inpatient immediately if they are experiencing non-suicide self-injurious behavior, but in those cases, it becomes very critical to do a full suicide safety risk assessment to ensure that whatever services would be appropriate for that individual at the time. Family history of suicide. I'm so like particular about this. The family members who have done a suicide, I always have that in my mind, that put our children at a higher risk regardless. Active substance use, either used due to acute or chronic effects, exposure to adverse childhood experiences. I think either physical, emotional, or sexual abuse, or even experiencing domestic abuse in the house, or even like incarceration of the parents. So those all social determinants such as racism, discrimination, poverty, all those, the more the ACEs a child is exposed to, higher the risk for suicide in those circumstances. And chronic medical illness can certainly add a lot to the stress, and that can impact the emotional well-being and eventually put them at a higher risk for suicide. Acculturative stress in immigrants, especially when there is a lot of stress, there are a lot of stressor in the current geopolitical environment wherever you are living. These situations can also add significant stress to our families and to the children that we care for. And then there's something called suicide cluster. You probably know that when there is a Netflix series that was released, 13 Reasons Why, there was a increase in suicide in that month after the release. Uh, and the impact is the reason why I mentioned this is because many of our children, you senior offices are so much engaged in social media, like watching things on social media, TikTok, Instagram, or different platforms where these things get mentioned a lot, and making sure that there is a healthy exposure to social media is in regard to that, education to the parents is so important. So another one of the main other things that I feel like is so important for us to keep in mind is cyberbullying. Like 97% of our adolescents use social media, and I know that some of the states are even banning like use of phones in the school. Like New York is one of that state, and I know in Pennsylvania, a bill is currently in house to vote on if there should be a restriction of use of phones. Yeah, in the school setting. And one of the things that lawmakers are becoming more familiar is how that most of the kids, by research we have seen, is majority of the kids spend when they have phones, spend time on social media, and that comes with the pros and cons: negative impact on sleep, oversharing of personal information, exposure to harmful, inappropriate content, peer pressure, predators. And then there has been quite a few studies and literature that has already found, and even recent meta-analysis that was published, that victims of cyberbullying were at increased risk of attempting suicide, harming themselves, and having suicidal thoughts. So my thing is that in clinic, if I see someone having suicidal ideations, I always do inquire their social media use or even screen time use, and certainly educate the parent that while we get the situation under control, how much prudent it is for the parents to watch their online exposure, especially if there is a negative interaction that is happening, putting them at a higher risk, putting them at a risk for self-image damage, or even that can add to more stress and then suicidal ideations. So once we know that these are some of the risk factors, and like what do you look for? Like what are the warning signs? Something to look for. When warning sign means is something that we look out when concerned that person may be suicidal, is basically change in the behavior or presence of any entirely new behaviors. This is of sharpest concern if the new or changed behavior is related to any painful event, loss, or change. Most people who take their lives exhibit one or more warning signs, either through what they say or what they do. So as as professionals that we encounter on a daily basis so many children, our eyes and ears need to be open to see that what are the signs. If you are noticing any sign that can make you worried, or you don't want to miss and want to inquire more that what could be happening. For example, killing themselves, or they say feeling hopeless. Hopelessness is one of that risk factors where I always get concerned about inquiring about the suicidal ideations. If someone feels hopeless about, in general, about life, having no reason to live, being a burden to others, feeling trapped, feeling unbearable pain. So those are some of the things that words people may use, or children, especially older adolescents, to inquire more if they have more resources. And I also put in like mental health resource crisis here. There is a national suicide line, and also there is a crisis line. Certainly 911 is one of the things that more people, everybody knows, or 988 is another crisis line that they can talk with someone and get help. And in detail, some of the warning behaviors could be like behaviors that may signal risk, especially if related to painful events, such as like increased use of alcohol, or looking for ways to end their lives. Like they were searching, parents tell you that, oh, my son was searching for how to kill himself on the web page. That is very concerning. Not engaging in activities that they normally do, isolating from family and friends, sleeping too much or sleeping too little, visiting people or saying goodbyes to people, giving away their prized possessions, feeling excessively tired. So those are some of the things that can represent there is something going on. And then again, like mood is also an important factor to keep in mind. Any symptoms of depression, anxiety, they have lost an interest, irritability, humiliation, shame, agitation, or anger, relief, like suddenly they are all better now, who then have to be cautious that, okay, what could be happening in the mind, that a whole burden is uplifted. So that could be possible that they may have thought through something in their head to how to really find a way to relieve from their pain. So those are some of the warning signs to keep in mind when you clinically see these children. There is a video that I would like to show everybody. Let me see if I can play and if you can let me know.
As
Okay, let me just start. I think
pediatricians, we have the unique opportunity to make a difference for our patients and families by identifying and supporting young people who are at risk for suicide. During routine visits, we can follow a 3-step clinical pathway by conducting a screening, making a safety assessment, and identifying next steps of care. The first step is universal suicide screening using a validated screening tool. The American Academy of Pediatrics recommends universal suicide screening of all patients in every demographic, in every setting, who are 12 years and older. Screening for depression is important, but might not be sufficient. Universal suicide screening is the best way to identify kids at risk. And any member of your clinical team trained in administering a screening tool can start by taking about 20 seconds during the visit to talk about suicide. This can become part of your workflow or added to your EHR. Ask thoughtfully and directly. Have you been having thoughts about killing yourself? Listen to their answer to help inform your next step. Once you know a patient is at risk for suicide but not in imminent danger, ask in subsequent visits. Last time you were here, you told me you had some thoughts about suicide. I wanted to check in with you about that. Remember, screen patients at least once a year, even for those who have no history of suicide risk. Most young people keep suicidal thoughts to themselves and might not bring this up on their own if they aren't asked a direct question. Even a patient presenting with other health concerns or simply coming in for a regular checkup can have pressing mental health concerns that they aren't talking about with anyone. Without these direct conversations, our patients might pass through their visits with us without really being seen. In the next video chapter, I'll go through the second step to take when your patient has a positive screen. Let's say you have a patient who told you that they have thoughts about killing themselves. The next step is to conduct a brief suicide safety assessment, or BSSA, to help you decide whether it's safe to send them home or whether there's a need for immediate intervention. You and anyone in your practice, such as a nurse practitioner, physician assistant, or mental health professional, can perform a BSSA after proper training. A BSSA is a 10 to 15 minute conversation with your patient that helps you evaluate their personal risk and protective factors related to suicide. It includes your patient in the decision-making process for their treatment options and sends a message that mental health care is a collaborative process. To start, you might ask how often they think about suicide, if they have specific plans, or whether they've attempted suicide before. Ask if they've thought about reasons to live and what social support systems they have. If your patient screens positive for suicide risk, tell them carefully and thoughtfully. Explain that you will need to talk with their parents or caregivers and ask them how they would like to be involved in that conversation. When talking with parents or caregivers, ask if they know about their child's suicidal ideation or behavior in a way that does not come across as blaming or judgmental. You might say, "Your child spoke about having suicidal thoughts. Is this something they've shared with you?" Be aware that young people are often private about their suicidal thoughts, and it's common for parents to be unaware of this. The BSSA is important because you want to provide care that matches the level of risk unique to the patient and not to over-respond. Not every conversation will lead to a full safety precaution response where your patient goes right to the emergency department and is admitted with a one-on-one observer or sent to a psychiatric unit. This response is only meant to keep kids safe who are at imminent or acute risk of harming themselves. Regardless of level of risk, all patients and their parents should be given the 988 Suicide and Crisis Lifeline and Crisis Text Line. Consider texting the line with your patient while they are in the office to help them feel comfortable and familiar with the service. Those patients who aren't in imminent danger do not require safety precautions, but may or may not need further evaluation. I'll cover high, medium, and low risk levels in the next video chapter. With your patient in the office,
that should cover the basics, and I'm gonna go and share my slides again. We can take it from there. Can you see my slides, Mindy?
Not yet, but again,
Not yet.
just going back to the screening tools for preteen for under 12.
Yes, under 12, usually there are two screeners that are commonly utilized by professionals. One of them is the Columbia Suicide Screening Scale, and then other one is ASK, which I'm going to talk right now in this, which was talked in the video as well. So basically, anybody 8 and above is something I recommend ASK to be utilized, because there is a research evidence showing that ASK is more helpful in picking on the way language is utilized. It's more able to pick on, more effective in picking on positive suicidal screening. But anybody 12 and above, you can use either ASK, or you can even utilize Columbia's screening for that they made for children. So your recommendation right now, up until now, the scales we have 8 and above, but and for Columbia it's 12 and above. So those are the ones that we utilized in our clinic. But below 8, there is no evidence-based recommendation for scales. But I utilize either talking with the kids on, like, verbally asking them, and then using the ask in those patients also. But then they're gonna need more like clarity on your language, how you ask those questions who are younger than 8-year-old. I hope that answers the questions, but certainly there is a research gap over there that what scales to utilize if it's below 8. So then there is another thing, is there a missed opportunity? So what the research has shown that most of the kids who, like children that died by suicide, have had contact with medical professional within the last 3 months. And 80% adolescent visited the healthcare provider within the year prior to death by suicide. 49% of youth had been to emergency department in that year, and 38% had a contact with healthcare system within 4 weeks prior. And they frequently present with somatic complaints. So I think this is where our universal suicide screening plays a role, where we are not able to miss on these cases. Suicide screening versus assessment. Screening is more to identify who are at risk, could be done either computer, oral, pencil, paper. Risk assessment is more comprehensive, as was talked in the video, can take 10 to 12 minutes. Comprehensive evaluation, where you confirm the risk, confirm the imminent risk, and then guide them in the next steps. 3 screening tools, as I talked before: Columbia, SCSSR, PHQ-9 also has number 9 question asking about suicide, and then ASK is another, which is suicide screening questions. That is also 8 and above screening tool that is evidence-based and very quick to do. We utilize this in our clinic quite significantly. There are 5 questions, and then very easy to implement and does not take a long period of time to do it in our clinic visits. So this is evidence-based clinical pathway, brief screening, as we talked about, and then ASQ is validator tool for 8 and above. It's freely available from NIMH website, available in multiple languages, and suicide risk is suspected in younger children. Full mental health evaluation is recommended just instead of screening, and the more so because we do not have evidence-based scales yet to screen appropriately children who are younger than 8. Steps in screening and assessment. Like this is the ASQ question, ASQ scale that has 4 questions. In the past few weeks, have you wished you were dead? Have you felt you or your family would be better off dead? Have you been having thoughts about killing yourself in the last week? Have you ever tried to kill yourself? So these are the questions in the 5 questions in ASQ scale. If yes to 1 to 4, that's a positive screen. But no to question number 5, which basically says, are you having thoughts of killing yourself right now? So question number 5 is no, which means it's a non-acute positive. So then you perform the BSSA because 1 to 4 question were positive, and then assess if the full mental health evaluation is required. If there is a yes to question number 5, that means patient cannot leave and is in imminent danger and needed a higher level of care, either taking them to the emergency room or making a treatment plan from there, what to do next. So this is a BSSA, which we also talked about, like this is going in more detail, like how do you talk with the patients about those once you have a positive response, assessing the patient of what is the frequency, how often these thoughts are happening, have you done anything to prepare yourself to do any of act on those thoughts, and what was the suicide plan? Do you have any plan to kill yourself right now, or what is your plan if you're going to kill yourself? How would you do it? So basically assessing the further steps through BSSA, and it lays out very nicely how to ask these questions and then what would be the next steps once you ask these questions. And this is also freely available. And then the second tool is the PHQ-9 that has number 9 question asking about how often you've been bothered by the following thoughts during the last 2 weeks, thoughts that you would be better off dead or hurting yourself in some way. And this is also publicly available in public domain and commonly used in medical settings. So this can also be a helpful question. But then they also compare the ASQ versus PHQ-9, like how the medical health professionals can get the guidance that which screening do we utilize. So this was data from 600 medical inpatients, out of which 60% female, 55. So pretty comparative male and female ratio. Mean age was 15 years old. So of participants who screened positive for suicide risk, 13.5% positive were 13.5%, 39% did not screen positive for depression. More than half did not endorse positive on PHQ-9, which queries for thought of harming yourself or being dead. 26 participants who screened negative for depression on PHQ-9, item number 9, were again also at high risk for suicide. So basically, there are like what they're trying to say is certainly PHQ-9 has a missed opportunity at times compared to ASQ. And there is another question that I usually get asked, like where parents get a little bit hesitant that if you ask about suicidal thoughts, is it going to increase the risk of suicidal ideations, suicide in those children? So this is the data from 192 pre-adolescents, multiple races and ethnicity, which showed that there was no evidence that repeated screening increased suicidal thoughts in either group. In the lower risk group, positive screens were rare, with no significant increase over time. In higher risk group, 7% of the screens were positive, but this frequent screening did not exacerbate suicidal thoughts. So we can assure our parents that asking about suicide does not increase the risk of suicidal ideations in the future. So this is the suicide risk screening pathway. I'm gonna just widen the slide a little bit just to make sure that if you can see it. Oh goodness. Now the computer has to go.
Folks will have a copy of this for their reference as well.
Yes, yeah. I think it's just sorry about that. It just went restarting. All right, I have to share my screen again. Sorry about that. Yeah, so there was a full pathway that you can utilize from suicide risk screening to brief suicide risk assessment, and then finally making a plan with the disposition. I think for some reason, Mindy, on my end, my laptop is shutting down for some reason. Oh, here we go. Open it up. All right. Thank you. That is great. I'm going to share the screen in a second. Sorry about that. Technology sometimes take over.
You're doing great. And a reminder that this will also be available recorded session on YouTube as well for enduring
Yes.
hearing.
Yes. So this is the suicide risk screening pathway where you assess the question if you administer the ASQ, and if there is a positive. We talked about what is acute positive, where is non-acute positive. When it's acute positive, that means that's an imminent risk and you have to follow the safety risk assessment plan and then make the decision if the patient needs to go to inpatient or further mental health evaluation would be recommended. And then if there is a non-acute positive, which basically means is 1 to 4 questions are positive, then you have to determine, is it a low risk where patient can be continued as it is, or referral for certain type of services, therapy or psycho or medication management would be beneficial. And if it's intermediate risk, that's where you have to decide that what should be the next step in treatment. Either there is an underlying psychiatric disorder that needs attention, or referral to a child psychiatry would be more beneficial in those cases. And see, in the safety planning, I think that's where the most important part comes in, that in regard to safety planning, one of the things that is that sometimes the kids do not share the feelings because they get worried about what is going to be the response of the parents. So really talking with the children that this is something that needs to be shared with grown-ups, and then collaborating with all together as a family unit. I think I have seen that as very successful. Yeah, in which way the parents can be supportive and be there for them and kind of watch them, even if we are ending up discharging them from the clinic and not wanting to go to immediate, like higher level of care. Talking about coping strategies, like what are the things they are going to do when these suicidal ideations, if they become worse, even if they are not worse right now, but what they can do as they go home and these suicidal ideations get worse, what are their resources, who are they going to tell? And that's where I think I sometimes have challenge if the children are not able to come up with the plan. That's where I get very worried that how are we going to ensure that you are safe? Many times it happens especially in circumstances where there is a poor relationship between child and the parent, or there is some kind of stress such as domestic abuse or violence happening in the house. Those are the situations have to be kept in mind before making the decision for the disposition. And social contacts for support, such as friends or peers, or even have a therapist to support them, or school counselor. Like, what are the things that, who are the people that a child is able to feel comfortable, able to talk with them if these thoughts get worse. And then definitely talking about emergency contacts, who they can connect immediately if they are having suicidal ideations. And last but not least is making sure the safety is secured at home, like access to lethal weapons or firearms. Are they locked separately? Ammunition is separate from the weapon and they are locked in 2 different safes. And then do the children have access to those safes? So who has the access? And then another thing would be talking about like medication access or any sharp objects in the house. So really important to bring those things in attention to our parents if we encounter any patients who have suicidal ideations or even suicidal thoughts. So takeaways: early intervention of risk factors and timely intervention can reduce overall mortality and morbidity. American Academy of Pediatrics do recommend universal screening 12 and above and screening when clinically indicated 8 and above. Under years of 8, recognize the warning signs and assess for risk. So it all comes down to under age of 8, since we don't have any evidence-based research tools to do the screening. Certainly important is your clinical interview in those circumstances. ASQ screening and risk assessment is a validated tool, has a lot of research evidence based behind it, and it can be easily implemented in your EMR as well. And it's very easy to perform and takes very little time out of our busy schedule. Depression screening, PHQ-9 may not be just only sufficient because there may be missed opportunities in there. So doing a safety suicide screening separate is critically important. And then educating the family about safety planning and access to the lethal means. We may think at times that families will probably be aware of all those things, but I've been surprised where families made interventions after we discussed, and that wasn't even on their mind to do those things when we have such circumstances. So, and these are some of the resources in Delaware and ACAP also, American Academy of Child and Adolescent Psychiatry also share a lot of resources. And these are some of the reference, all the information that was shared. There are a lot of references and evidence based behind it. So that will conclude the talk on my end. I